is Hannah's mom. She is our ambassador's mom. So nice to have you both on screen.
Hi there.
Hi.
Would you say that, please?
I think we just give Zewe a couple of minutes, just getting some food. Okay, we'll start. Maybe a little trivia question after the afternoon slump. Hopefully you guys haven't fallen into it after all that sugar. What do you think the most overused word of the day has been? Any ideas? A word that has been used the most today? Agnes? Yeah, close. I think screening has probably been one of the most used words, obviously in a good way. So, just to start, at this point in time, this is a caregiver's presentation. It'll really be informal. I think it's very important, particularly for our medical experts and people who have come to support us, whether here or online, to understand that sickle cell disease is very much an invisible condition. It's insidious in how it pervades through your life, for obviously our warriors and also for caregivers. So most times you find that caregivers and warriors walk parallel paths, but very much lonely, and we live for moments where we hear things about what's happening in the science and how it's evolving. So without giving away too much, I'll probably just move to Dilys, who will introduce herself and tell us about her experiences. Whatever you want to share, Dilys. Do you have a mic?
Hello everyone. Okay, so as Natalie mentioned, I'm Dilys, a caregiver of a 2-year-old. Okay, so what I'm gonna share is basically my experience initially knowing about me carrying a sickle cell baby and moving forward from there. So yeah, I did have a basic knowledge about sickle cell disease from family history. So I had to get my husband and I to go do testing, and we did realize that we've got the traits. At the time, I didn't really think much about what next to do, and unfortunately the doctor we saw as well did not tell us anything, just told us the chances of sickle cell baby, and that was it. And which I think being involved in ASCA at the moment has been one of the things that keep playing up in my mind to help in advocating and putting the word out there, including GPs and other doctors as well, so that they can talk to the couples who come in after the testing, maybe tell them detailing what could happen, or maybe send them out for genetic counseling and to make an informed decision from there. Yeah, so I did go ahead to have a baby. I got pregnant, and then it just clicked in my mind then, I could have a sickle cell baby. That's when it actually clicked. So I went in now for more talks with the doctor, with my GP. I got sent to for genetic counseling, and then from there we did CVS. We decided to carry on with pregnancy after a few weeks of deliberation and everything. I mean, with counseling from doctors and talking to friends, that really helped us to move forward. So at the moment, baby is doing really well because he was screened again when he was born. they discovered he's actually got the confirmed that he's got sickle cell disease. So with that information, I think that helped a lot throughout that beginning stage, because it provided the care we need, both emotionally and physically. So baby is doing really well now on hydroxyurea, and that's one of the main reasons as well why I'm a big advocate for newborn screening in Australia, and I really pray and hope that goes in effect as is currently in Parliament. So that's it I'm gonna talk about, really.
Okay,
thank you for
thanks,
listening.
Delis. That was a great sharing. And Zere, what words have you got to share with regards to being a warrior or a caregiver?
A bit of both. Being a warrior and a caregiver to a friend of mine as well, a brother, it's more of something that I think the biggest part that needs to be looked at is the mental health aspect. I think there's a little bit of a discrepancy over there where it needs to start at a very young age, like possibly therapy, because it can be quite a very lonely road, trying to understand your own disease and also trying to understand what these big words the doctors are using, and hearing hydroxyurea and you're trying to tell your mom, what does hydroxy mean, and it takes a toll on you, and trying to also relate to your younger friends or your friends at the same age. It's a very confronting disease, as it would be with any other disease such as cancer. And also on that note, it being a
Blood disorder.
a blood disorder, you're constantly seeing also other kids that are going through cancer. It can be quite confronting because you don't know where you stand, whether you're going through the same thing, whether you're going to lose your hair, and so I definitely think therapy is something that definitely needs to be advocated a little bit more on for younger kids, maybe age 7 or up, even if you could start at age 5 and slowly introduce that and allow them to talk, because I think a lot of warriors are silenced by that, or because they just don't understand what's going on with their bodies, even through puberty, because you're going through something, you're learning about how your body's growing, and then also trying to focus on another aspect of your life, trying to manage this blood disorder. So it's definitely something that I definitely think needs to be expressed to every parent and every child too. Yeah, that's all I could say.
Thank you, Zira. That was wonderful. And then we'll go online. So where we have Karen and the lovely Hannah. Hannah has spoken quite extensively about her experiences. So always wonderful to hear from her. But I'm more interested in Karen. Karen, can you share what your experience has been as a caregiver? And I think maybe just to add to that as well, knowing that Hannah is, transitioning to teenagehood soon.
Absolutely. We're on the cusp of adolescence here.
Yeah.
She's 12. She's got sickle beta 0 thalassemia. And it's been quite a journey. I think I concur with some of the previous speakers that as a caregiver, it can be quite a lonely journey. I think for Hannah and myself, joining ASCA has helped us to feel less isolated. And for Hannah to feel that she's not alone in some of the issues that she has to contend with on a daily basis as well at school. That sense of feeling different, not being able to do everything that other kids maybe do, but that she still has value in what she has to offer and what she is able to do. So it's about a careful balance, building up a resilience, and she's proven to be a resilient little girl who has, young lady, I should say. Let me not step on anybody's toes here.
Okay.
She is growing up. She's going to high school next year. We've got a whole number of transitions that we are negotiating at the moment. The transition to high school, the transition to adolescence. And it's good to know that there are, because it's such a rare disease in Australia, we live in the country, it's not that easy to link in with other families who are in a similar position and are contending with similar issues. So being part of ASCA has given a greater sense of belonging for Hannah and for myself and my husband as caregivers. She wanted me to add a few other things. If you want a full history of my experience, then you'll have to purchase a copy of the book The Many Faces and Lives of Sickle Cell that we recently published. The full story is in there.
I don't think it's quite the full story.
Well, most of it. And so I've got a chapter in there, so I'm not going to go into that right now. But Hannah just wanted me to say that for hydroxyurea, it tended to be her magic medicine. For the last 5 years, she's been doing really, really well on hydroxyurea. She no longer needs transfusions every 2 to 4 weeks, which came with its own pressures and risks and advantages at the time. She's had this massive growth spurt, and she's finally caught up with her peers in terms of weight and height. She was the tiniest little girl while she was still on transfusions, and she's sort of come into her own in the last 5 years. So I would like to encourage other families to consider it as a possibility as well, to use hydroxyurea as a form of treatment or alternative form of treatment if it's the right fit for their child and their family. What else? We spoke a lot about transitioning today, and I'm all for this biopsychosocial model where we have a wraparound care system for the young person and their family as they negotiate their various developmental milestones and transition from pediatric to adult care. And it's wonderful to hear about these programs that we are just going to be entering into now because Hannah's 12, and we're at the beginning of negotiating those muddy waters, and we're expecting it to be a further learning curve for us. I agree with the importance of encouraging your child to be more self-sufficient and independent, because ultimately that is our job as parents anyway, to teach our children to be as independent as they can for the times that we might not be around to be there for them, and that can or to advocate for them, and they're able to better advocate for themselves as well. And that is something that ASCA's provided the foundation for us to be able to do that more efficiently, particularly Hannah, being able to feel comfortable in her own skin and talking about her condition in a country school where it's not something familiar, and educating and raising awareness about that, not only for kids with sickle cell disease, but also for other children with chronic illnesses and some of the challenges that they face, particularly during these COVID times, times of the pandemic. I think it's been trying for all children, but I think children with chronic illnesses, the stress that came with that could be quite intense as well, and it's often underplayed. What else? I like the fact that, I think it was Claire that said that transition is an evolving organic process. Absolutely, I believe with that, and it must be matched to the individual and his or her family and the biopsychosocial context that we spoke about. And the holistic care, I think that is also something very important as well. The last thing I wanted is just to say, I like the fact that we've raised something about having more open discussion and raising awareness about things like sickle cell trait and symptomatic sickle cell trait examples, because it seems to be quite a contentious subject. A lot of disagreement about it, but I think it's good to put these things on the table and to invite debate about it, because I think if we just say across the board that if we have this huge resistance to raising awareness about the symptomatic sickle cell trait, that in some instances that, and for many people that have come forward now, they said it's not something benign for them. By just saying that you're not going to address it, and it's not something that's experienced as often, that you're actually silencing a whole cohort of people, you're silencing their voices and their experiences of maybe having symptomatic sickle cell trait symptoms. And it's just something, it's good to have an open discussion about it.
Okay. Thanks, Karen. And thanks, Dilys and Zewe, for your powerful insights. I think, once again, just to bring back to the force that these experiences that caregivers and warriors share do help our clinicians and experts to help improve the levels of care that we are provided with. And also that, with sickle cell disease being an invisible illness, it's not just physical, it's very much a mental one as well. So a lot of consideration has to be taken care of in terms of that holistic care. Thank you.
Thank you, everyone, for sharing those lovely insights. I think I'm taking a couple of things away back to ask the lovely people I'm looking after when I get home. The next session, which I've been instructed to try and keep to 15 minutes, is about sickle cell disease and education, and we're going to do that as a panel discussion. So I believe we have Dr. Anthea back up here again, and Dr. Elizabeth Palmer, or Emma. Please join us up here. You should just stay here. Just stay here. Thank you. I must admit, don't have any questions yet, but maybe I'll start off by asking if you guys wanted to start sharing some comments with us about education and sickle cell disease. Sure. Thank you.
So I haven't spoken today, so you don't know who I am. I'm a clinical geneticist at Sydney Children's Hospital. I'm also a senior clinical lecturer at UNSW, and I've got a lot of interest in translating after a diagnosis of a rare disease, often a rare genetic disease, into improved patient and family care. So I'm part of a national program called Rarest, which is funded by the Australian government, where we're trying to improve awareness, education and support around the mental health impacts of rare conditions, which we've heard a lot about today, about trying to reduce that isolation and uncertainty, trying to really educate and work together with all types of healthcare professionals, including GPs and primary care physicians, about awareness of the particular challenges of a rare disease, and equipping them. So one of the things that we're launching next month is a rare project Echo, and what that is, it's just held on Zoom. And we have a group of healthcare workers. They can be nurses, allied healthcare professionals, GPs, specialists, and they come together in a Zoom room. There's usually a short presentation about a topic, so that might be about the mental health impacts of rare disease, for example, or difficulties accessing clinical research for rare disease. So an expert talks on that, and then the people that are part of that team come and talk about their experiences. So they may talk about why they're finding it difficult. Maybe they're in a rural area accessing a specialist in their patient's care. And so everyone kind of shares knowledge together, and we're backing that up with some other resources. So there's an e-learning module that will be freely available about these kind of principles of rare disease care. And one of the main things that comes out of this is this idea of person-centered care, which was really beautifully demonstrated before by what it means is not going in as a doctor with your preconceptions of what I think I need to tell you as a patient, but I listen, and it's a partnership. So it's really about then trying to model the care to something that makes sense to you. And I think we heard beautifully in that transition talk that if you go in almost as a school teacher and say, oh, your results aren't good because you've not been adherent with your teacher, that just breaks down that trust and that partnership. So it's really, taking a different approach and saying what's been going on and getting to know you as a person. I think that's something that haematologists are incredibly experienced at and very dedicated with their patients and their families. So that's what I do, as well as a lot of genetic stuff that's probably a bit boring, but the bit relevant to this is about that. So I guess that may be some solutions that you could look at in this community is things like Project Echo, which is really about trying to empower local healthcare providers and a range of specialists to really provide that multidisciplinary care.
That sounds really amazing.
That's fantastic.
Dr. Greenway, do you have anything you'd like to contribute?
Look, I suppose just if we think about sickle cell education globally, there hasn't been a sort of systematic approach, and this is because of the worldwide incidence and inheritance we've heard, there is a need to know about this disease in every country, and it needs to go right back to all our sort of primary care, ED, nursing, medical, just needs sort of very basic information, I think, so that people at least know what they may not know and when to call for help. And that hasn't been systematic in any country of the world, even in countries where there is a lot of sickle cell disease. So I think that will remain a focus, and there's not yet a solution, but there is global effort to try and improve things. There are lots of resources online for both patients and families and also clinicians, and so every one of the sort of American Society of Haematology, the UK Society, they all have resources. So it's not as if there's not resources, it's just I think people knowing where they are and how you put them together and what is the right model for the right people.
Absolutely, it's quite a complex area, isn't it? And I guess one of the areas that we've been looking, and obviously I'm from South Australia, has been not just educating the medical fraternity or educating the families, because we all do that when we see our families in the rooms. We try and stick as much education as we can in, but also the education of the children, and not just about sickle cell, but their education process itself through the mainstream schools, and how do we support them to do that. And certainly in Adelaide, our cohort of families are from migration and refugee backgrounds, so English is not their first language, and that's certainly a barrier that I'm finding really hard to break through, because there's so many different languages. As a matter of fact, I only know how to say 2 things in Swahili, and I'm yet to learn more. But it's about I suppose empowering the schools and the teachers there about how to look after these kids as well. And so we're at the infancy of trying to get that sorted. But the resources are still, you have to gather those resources up and be able to provide them. And all my parents have come in and said they definitely have found the recent allocation of a school liaison nurse from our hospital really helpful. And as a matter of fact, it's probably now that my clinic has suddenly realised I actually look after people with sickle cell. It's suddenly become a thing because now we've got nursing staff talking about it as well. So education, I find, is not just the medics really. Is that very good? So many aspects to it. Were there any questions or comments from the floor about education and sickle cell?
Natalie?
Just grab the mic.
Thank you, Dr. Manika. I'm quite curious to hear about the school liaison officer, because that is so key. Because as you mentioned, a lot of children who have sickle cell disease are certainly impacted by missing school days. And what you find is that obviously as parents we have to work with the schools, you know, to ensure that our child is successful despite these, you know, these difficulties and challenges. But at times you find that the schools themselves are not always very well equipped to support the children. So it's not from lack of wanting to do that. And we find that we could certainly use, you know, more support even as parents who most of the time are probably working as well. At the same time trying to look after our children to the best of our abilities.
Of course, I absolutely hear you, and I think I have to very much acknowledge the lot of hard work that our nurses put in to try and get this project running. So it started off with the oncology department, so I do both hematology and oncology, so our department covers both aspects, and we certainly have a hospital school, and we have a school liaison nurse initially set up for the oncology services. And really after many years of barracking and advocating, finally myself and the nursing team that I was working with managed to convince the funding body to say they need to cover hematology as well, not just oncology. And obviously when we say hematology, it's the transfusion-dependent children and children with sickle cell disease that really need that work because they are spending majority of the time in hospital. But it can extrapolate out to so many more. So we started off with that group, and our school liaison nurse picked that role up. She's come up with some education material, school booklets. She liaises very closely with Mwewa from ASCA SA to make sure that there is a connection through there. She goes out and makes school visits and actually talks to the principals and the teachers and the school nurses involved. They all have reading material and information material. This is all done after getting permission from the parents, of course, to go and do that as well individually. So it's a very individual approach. And at the moment, I guess it's individual because my numbers are probably not as big as the rest of Australia, but certainly for our hospital, it has finally made the mark of saying we do have a bunch of really amazing kids who need some support at school. And so far the feedback has been amazing, and as a matter of fact, we now have families calling up and saying, we've heard about the school nurse, and so that's how they engage with me. They don't come to see me, they want to see the school nurse and make sure they've got an appointment with her. So that's really good.
Great. Thank you, panel.
Thank you.
Okay, on to our next panel, moderated by Agnes.
Is it evening now? Or good afternoon? Say afternoon, or is it evening? What time does evening start? Well, we are almost there. So at this point, we've got Pat joining us on Zoom, and we've got Kate Holiday from Sweden, and we've got George who's here, and we also have who else? We have Natalie. Mwewa, George, Kate on Zoom, and Pat. Have they joined already? So this session is about what we do and why we do advocacy and how we should do it. No right or wrong answer, so we are here to learn, but I'm super excited and thankful to have George joining us today. George is a president for Thalassemia and Sickle Cell in New South Wales. So he's with our team representing people impacted by sickle cell disease. So I'm excited they're hosting us, and it was very lovely to meet you finally face to face. This is Mwewa. She's from our South Australia team. Yeah. So do we have the rest on Zoom? Kate Holiday and Pat Bollard from Victoria. It's been a long day, but we're almost there. Yeah? Okay. I can see Kate. and Pat is not on screen yet. Hi, Kate. How are you?
Hi, well, thanks. Nice to be here, Agnes.
Nice to see you. Thank you so much. So Kate is joining us. Are you you're in Sweden, right?
Switzerland,
Switzerland.
close.
Sorry, Switzerland. Yes. How can I meant Geneva in my head. And Pat is the president for Thalassemia and Sickle Cell at ASCA in Victoria. So we work together in Victoria, and thank you so much for joining us. So we deliberately included this session for us just to relearn and teach and learn between ourselves why we do this, and specifically invited Kate, who's done a lot of this work. She inspires me, and one of my mentors, like Monica and a few others in this advocacy space. That's why I actually invited her. To begin with, I think I'll just do self-introduction briefly, because we have a few minutes because we're running late, and then we just go into it and contribute what you have. So George, over to you. Thank you.
All right, thank you. Do I need this? Or?
Yes.
So, hello? Yeah, there we go. So I guess good late afternoon, everyone. Thank you first of all for having me here today. It's I really appreciate it, and it's a fantastic job that you all do. Obviously, we're all joined together for a very important cause. I'm George Hussos. I've been the president for the Thalassemia and Sickle Cell Society of New South Wales for about 8 years. It feels a lot longer. But our society is now close to 45 years old. So we've been through, I guess, seen the whole spectrum of thalassemia, sickle cell in New South Wales, and different things to how we address how we've dealt with this and our advocacy and our education. So hopefully I can give some insight to that this afternoon.
Yes, thank you.
Hi, my name is Moa Chisenga. I am a mom. I'm a mother. I'm a finance professional. I'm a caregiver living in South Australia. And again, I'm helping with the ASCA chapter in South Australia, where we have a few volunteers that work with us, again, in the space of advocating and raising awareness, particularly of sickle cell. A few of us, as we call it, have skin in the game, because we have either children living with sickle cell disease themselves or are carriers ourselves. And so we're coming in from that particular space, and others just coming in to go, I need to know how I can lend a hand and raise the voice into this bigger issue that's actually affecting our community.
Thank you. Thank you so much, Moya. Kate, thank you.
Good afternoon, everyone. I'm the Chief Executive at the Centre for Community-Driven Research, and I also run the Pathways Telehealth Nurse Service across a number of rare disease, and that's a program that ASCA is actively becoming a partner of, and we're really excited to work with Agnes and the community on this. I'm also a telehealth nurse for people with rare and genetic disease, and I provide that service for the GUARD Collaborative.
Thank you, Kate. And finally, Pat.
Hi, everyone. My name is Pat Bollard, and I am the chair of Thalassemia Sickle Cell Australia, based, as Agnes said, in Victoria. Can I apologise for my background? I can't seem to rotate it. So, but I've been the chair of TASCA for just under a year, and obviously doing a lot of work in advocacy and in education around Victoria and further abroad now. A lot of our work is focused on supporting patients, but also on educating the community around not only the conditions, but also what it means, the importance of genetic testing, the importance of testing full stop. And some of our education work has been in schools, and some of it has been in various community groups.
Thank you. Thank you so much for that, Pat. Well, I guess the question I have in my mind, like sometimes I have this answer, like, why do we do advocacy, like in your own ways? What drives you? Why do you stand up, knowing that, especially for, I think all of us here volunteering, why do you do it, and what satisfaction do you get from it?
I'll lead off. I think we're all touched in many different ways Some of us either have friends who are patients of thalassemia, sickle cell, others are involved in the health sector. But I think it's also we're motivated because there are so many challenges in our space. And if all you have to do is look around the world to see how different the outcome can be if you have good advocacy, good healthcare system, or if you don't. Now, sadly, we see people with thalassemia and sickle cell around the world, their future isn't as bright as it is in Australia. And that hasn't come easy. That has been, I guess, for us, 45 years of campaigning to increase awareness, improve treatment, and also remain vigilant. And it's gone through cycles. As the many different migration patterns have come to Australia, they've all had different needs and different levels of advocacy that we've had to do. Also, I think over periods of time, and I can only really speak about New South Wales, there have been moments where I could say that our healthcare treatment was world-class, best practice in the world for thalassemia and sickle cell, and other times where it hasn't been. And it's always a tough challenge because when you look around the world, yes, it is much better here, but that doesn't mean that we should ever be complacent. And it's always trying to be in tune with our members and their patients and caregivers to know what their needs are, to always be at the forefront to make sure you're relevant to your members and your patients in your advocacy. And it's not easy. We don't have the huge numbers that some other organisations have, and yet it is still the most common genetic disease in the world. So, but it's finding that balance where you can get people's attention and be relevant to our patients, because it's twofold. It's one, improving the healthcare outcomes, but it's also a great deal of advocacy within our own communities. And balancing those two things can be difficult. We're all got very limited resources. And I guess what I would like to do moving into the future is rely on more events like today, where we can partner with each other and collaborate a lot more often, because we all have shared goals and objectives.
Yes, thank you so much for that. Moira.
Thank you. I guess, why am I doing this? Really, if I break it down, why am I doing this? I guess, again, being a mother with two daughters who have sickle cell disease, I guess it was from that perspective. I wanted to inform myself better. How do I navigate and help my children through this journey? Because let's face it, as a carer, my experience is quite different from theirs. I'm learning about vicarious trauma and those things that are going on that I see my children day in and day out. We're going to the hospital, being pricked and all of those things that they got to do. And I'm going, wow, this is life for them. What can I do about that? And as I go into the hospitals and having to interact and meet other mums and dads who are also going through the same thing, and some are looking quite helpless, and they're kind of looking up to you in a way, like, oh, you're able to articulate, you're able to do some of those things. So you go, I think I have something to say, so I am going to say it. I am going to use my voice in a way that I can raise awareness, and again, those communications and collaborations that we tend to do as women, as parents. I'm having issues with my child. What did you do? How did you figure this out? And through that, you start to build networks where you can share information, you can empower each other. So again, one of my passions is how can we raise the level of discourse as a carer? When as a carer I'm having a consultation with the doctor, what sorts of things can I be asking them that can improve the health outcomes, that can improve the awareness, that can improve the understanding that as a carer, but also the same persons that are living with sickle cell, how can we empower them again to self-advocate? Because we know I can't always be there with them all the time. So how do I take them on that journey? But now on a much bigger scale, as our understanding is growing and our appreciation of the enormity of the challenges is ahead of us, you kind of go, I can't do this alone. I have to get out of my comfort zone. And being an introverted person, the last thing I want to do is be speaking publicly. Okay, but that's part of the growth. That's part of the growth thing where you go, I have to be comfortable being uncomfortable. Yeah. And that means putting myself out there. And that's not an easy thing for an introvert. So you go, okay, put my feelings aside. It's not about me. I'm just going to do what I need to do. And I think in that particular space, again, you start to give each other permission to kind of go, hey, it's okay. It's a bit scary, but we can do this together.
Yeah, perfect. Thank you, Moira. Pat.
just listening to what's been said, I think we have a number of members who have young children, 2-year-old, 5-year-old, who have, 3 weekly transfusions and all the rest of it. So for me personally, and I have a background in education, so for me, it is about educating the community. So it is about, so I went to a presentation that our health promotions officer did, and there was something in the presentation that clicked, and a whole lot of these girls got up and said, that's it, I'm getting tested. And to me, that was huge. That was a huge positive response from an audience to something that in some cases could have been, over their heads. But just as importantly for me is the need to support the kids. So absolutely the parents really are the first point of call when it comes to talking to doctors and nurses about their children's treatment. But it's also about holistically looking after the children. It's about helping them to talk about their condition in school, to help them to understand why they might have different requirements. One of our members used to say that he absolutely hated when he had to have a transfusion because it meant that he had to miss out on school, but then had to explain why he missed out on school. So fully empowering kids to be able to speak openly about their condition and to remove the stigma. The stigma still exists, particularly in migrant communities. So the older generation of Greeks and so on. The stigma still exists. So for me, it's really important to help get rid of that, break that down so that we can talk about sickle cell and thalassemia in the same way that we might talk about anemia or whatever else. So that's my mission. That's what I would really like to see happen.
Thank you. Thank you so much for that part. Kate.
Thanks, Agnes. For me, advocacy is about having the courage to provide support to help express the views and wishes of those that don't have the power or the opportunity to have their voice heard, and standing up for them and their rights. And the focus has to be on it being their voice. So being an advocate is really all I've known in my professional career as a nurse. It's one of your core competencies to advocate for the best care for your patient. And in my role at CCDR and in the Pathways Telehealth Service, it's advocating for system change that is not just about equity, but it's about equality. So when we talk about equity, we need to remember that it's about everyone having access to services, but striving for equality means that those services meet the needs of all the stakeholders, and that's incredibly important in rare disease. And as you know, I work a lot across a number of countries and jurisdictions, and in theory, we have a lot of opportunity in Australia for advocacy in health, but it's not without barriers, and there really isn't equitable access to decision makers. And small organisations, small patient populations are always going to struggle to have their voice heard and access decision makers. It's often given, that access to private sector stakeholders and large established organisations. And I'd say this is probably one of the biggest challenges in advocacy, is actually having the opportunity to advocate.
Yeah. Well, thank you. Thank you so much for that. And just wrapping up, George, you spoke about vigilance and being vigilant. How do you bounce back, being that vigilant? So if you can keep it maybe about a minute each, sure, and we close up, and that will be it. Because, when we get knocked down so much, how do you just get up and say, I still have to pick up myself?
I think you have no other choice. I mean, and I don't say that lightly. I just, and touching on some of the points people said, you look at young children, you look at, I think of many friends who have passed away way too prematurely, and it is hard. We lack volunteers, we lack resources, but I guess it's what drives us as a group, that if we don't, then things will sort of fall apart and the outcomes aren't great for people. So I think it's just having that sense of obligation to other people, and not also letting down the people from the past who have done it much tougher than us.
Yeah, perfect. Moyo, as a caregiver, I think I've got a separate question for you. As a caregiver, like, how do you balance the fact that you need to advocate for somebody else, but you're also carrying this burden? How do you balance the two?
Great question, actually. It's difficult some days, but that's where I channel the mother in me.
Yeah.
You know, because in those instances where you're putting yourself out there, you're speaking for other people as well, and sometimes it doesn't quite come out either in the way that you intended or the response that you were kind of looking for. You're trying to organize things and people aren't coming up, and you're going, what's not happening? Do you know what I mean? And so you bounce back again and go, you know what? At the end of the day, it's not about me. It's not about me. It's about the people. It's about the cause. It's about all of these things that we need to do. So I tend to draw on that, actually, to be honest, because and you know how difficult it has been for you to drive and do those things and get to the places that you've gotten to now, where you just kind of go, if we were to go back and just go, how many no's have you had?
Yeah.
To the yeses?
Yeah.
You know, so you're going to go, I just got to keep going on, because, again, never say die.
Yeah. Thank you so much for that. Pat, the vigilancy, how do you just pick up yourself and, you still have to do it anyway?
It was really interesting. Somebody asked the question the other day, if we didn't exist, what would happen to our members, to our patients, to the people that we're trying to engage with? And that, I think, is what we need to bear in mind and keep going, despite the setbacks, despite the fact that, some people want to be ostriches and some people want to go, no, not me, or whatever it might be. We have to keep going because we exist for the people who need us.
Yeah, thank you so much. And finally, Kate, what advice, being a veteran in this field, what advice would you give all of us on this panel? Like, what are we doing okay? What should we improve on? How can we do things differently, approach different stakeholders? What ways would you give us? Thanks, Kate.
So in advocacy, opportunities will always come from collaboration, but we can't ignore that element of being in the right place at the right time. But that also only comes from never giving up and having visibility. So there are times you can prepare the best case, the best evidence, and it goes nowhere or it's ignored. And other times when your ask aligns with a particular message or government platform, and you're in the right place at the right time. But that's usually through sheer persistence. You just can never give up, and that's when things start to happen. But I know in our organisation, we also have the mantra that actions speak louder than white papers, and we live by that. We are advocates, but we don't just ask for change, we implement it, and we live that change. So for me, it's a really important part, is that you have to be willing to step up when patients need your help and not just counting on others to make that change. You need to be the change yourself.
Yeah, thank you. Thank you so much for that, Kate. We need to be the change ourselves. And with that, I want to thank my panel. I'm re-energized and back next year in Melbourne. It's been a long day, but thank you so much, Kate, Pat, George, Mwewa. We are in this together and never giving up. Thanks again.
Absolutely. Thank you very much.
Okay, close to the end, and our next presenter will be Dr. Kongolo Kalumba, who has been with us throughout the day. Dr. Kalumba, I don't see him yet on the screen. Okay. So
can
Dr.
you see
Kalumba,
me?
Yes, we can see your presentation. Yes, and we can see you. So Dr. Kalumba is a fellow of the Royal Australasian College of Physicians and a consultant pediatrician and pediatric hematologist with extensive pediatric experience. going on for over 25 years. And most importantly, Dr. Kalumba is one of our valued board members. He has really been instrumental to our organization. So it is an honor and a privilege to have him join us tonight to speak about SCD and COVID-19. Where are we now? Thank you. Welcome, Dr. Kalumba.
All right. Thank you very much, Natalie, and thank you, Agnes and ASCA, for the opportunity you've given to me to present today. It's always difficult when you present at the end of the sessions. Anyway, I think the topics about sickle cell and COVID is very important. It's important for many reasons, because it is a big number of people in the world with sickle cell disease. First of all, I would like to give just an outline of the presentation. So first, with understanding impact of COVID-19 on sickle cell disease. The second one, to discuss the incidence of COVID-19 among sickle cell patients and sickle cell threat, or however these perhaps are not known. And the third would be to discuss sickle cell disease and COVID-19 vaccines. And the last one will be where to go from here. So again, what are you talking about? So as we know, so it has been said again and again today, sickle cell disease is the most common inherited disease in the world. About 5 to 7% of the world population carry a mutation for monogenic disorder of hemoglobin, and each year around 300,000 to 400,000 children are born with sickle cell disease. And in the world, we have more than 100 million people worldwide with sickle cell threat. So it is a major public health issue. And just to show you again the distribution, which is important here, that the majority of children, patients with sickle cell disease or threat, they are in Africa or India, in poorly resourced countries where they basically have no much access. So why do you worry about COVID-19 and patients with sickle cell disease? First of all, there are a lot of unknown. So we don't know what to be long-term complications or outcome of a patient of sickle cell who been affected with COVID. Secondly, there's a lot of similarity in some symptoms between the two conditions, which can make it difficult for the patient to present on time to the hospital, also to the doctor to be able to diagnose accurately. Thirdly, there is certainly potential negative interaction and effect between the two conditions, as I will explain to you in the following slide. And the two conditions may have common mechanism of disease. So now we know that there's a number of factors which can affect or can cause a crisis on a patient with sickle cell. And I'll just enumerate a few of them. So hypoxia, which is basically a low oxygen level in the blood, can be due to the various reasons. But we know that COVID disease will cause acute lung injury and chest infection, which can lead to low oxygen level, and this can trigger a lot of complication on a sickle cell patient. Secondly, reduced oral fluid intake. So children, particularly children who are sick, they have trouble drinking or eating, and they may end up having dehydration, which can also be a significant negative factor for them. Increased inflammation, and we know that sickle cell disease, they have ongoing sterile inflammation, and we also know that COVID disease basically will lead to significant, particularly moderate to severe disease, to inflammation, which can be also contributing to deterioration of sickle cell patient. We know that COVID disease, when it's moderate or severe, particularly severe disease, induced coagulopathy, and this can also contribute to a lot of trouble on a patient of sickle cell disease. The other factors also, we are aware that the immune system in a patient of sickle cell is not optimal, and a number of sickle cell disease patients may have complications on their heart, so that on their heart and pulmonary hypertension, as has been discussed with previous presenters. So all these can be really a significant burden and negative factors on a patient of sickle cell disease who has COVID, who contract COVID and COVID-19 infection. So now, so I'm just going to here on this slide just to explain how COVID disease basically lead to significant. I'm talking about here moderate to severe COVID disease will lead to significant infection to death. So normally after transmission, just a short review of pathogenesis of COVID disease. So we all know that a COVID virus have a viral spike glycoprotein, which basically will attach to ACE2 receptor in the lung. And this is more complex than that, but the two basically will internalize, and this will lead to viral replication and downregulation of ACE2 receptor. So ACE2 receptor is very crucial in the body, and now we understand this molecule better. So I'll review here renin-angiotensin aldosterone system, which is very crucial for a survival of most of us. So basically you have two axes. You have the AC angiotensin 2 and AT1R axis, and you have AC2 angiotensin 1,7 mass receptor A2 axis. So if you look at on your left, if there's no AC2, basically your balance will go toward the left, and this will lead to significant increase in inflammatory response, cytokine release syndrome, macular dysfunction, oxidative injury, strong vasoconstriction, and increased blood pressure or blood pressure dysregulation, endothelial dysfunction and thrombosis, and proliferative effect on organ and organ fibrosis. It could be on affecting lung, heart, and the kidney. So the right side, so this is the axis which protect you basically. So lead to anti-inflammatory, anti-thrombotic, anti-thrombosis, and natriuretic, and inhibition of on a plaque formation. So you can understand that if your ACE2 is dysregulated, is downregulated, particularly for sickle cell patients who already have significant vasculopathy as a part of the system, so sterile inflammation, ongoing sterile inflammation, vasculopathy, and all the other factors, so upregulation of selectin P and E has been discussed before. So this will cause significant problem on a patient with sickle cell disease. Now, this is again to summarize. Normally, this renin-angiotensin aldosterone system, how it works is we have a chemical called angiotensinogen, which renin will work on, and then that will lead to angiotensin 1. And then you need a AC2 to go to the axis on the right side, I've explained to you before, to have this angiotensin 1,9 and then 1,7, and the mast receptor, and this is a protective pathway. But if you don't have this, your balance will shift toward the left, then the ACE will basically transform the angiotensin 1 to angiotensin 2, which will act on the AT1 receptor, and this will lead to all the trouble. So, so if we see, as we know, the people who develop severe, moderate severe COVID disease, most of them will have some sort of ACE2 deficiency conditions. So which are hypertension, diabetes, heart failure, metabolic syndrome, and we can now also add also sickle cell disease, because sickle cell disease patient also have a relatively ACE2 deficiency, even though this hasn't been adequately proven. So we just to explain to you again, when COVID disease, I mean the SARS-CoV virus will attach to AC2, and then will lead to down regulation of AC2, and then you have all this trouble here. So this study has shown that the children with sickle cell disease were found to have low AC2 level and high AC2-1 in the urine. So that's suggesting that there may be deficiency, which could contribute to the renal disease. So this again, just to highlight, so this risk factor for COVID disease, and kid with sickle cell or patient with sickle cell, certainly, theoretically, you can see that they are prone to develop a severe COVID disease. So this paper here by Hodgebon, so if this is a clinical outcome of COVID-19 patient with sickle cell disease, critical approach. So this one, they review about 71 paper related studies in 15 countries from January 2021 to October 2021. There was 2,000 sickle cell disease patients and 2,000 sickle cell threat. So the conclusions are that with sickle cell disease has mild to moderate disease overall, but they have 2 to 7 fold increased hospitalization risk, and also 1.2 risk of death compared to adults without sickle cell disease. So most children, however, we found to have mild COVID disease and a low risk of death, but some children with sickle cell disease with comorbidity, sickle cell related comorbidity, have found to have increased hospitalization risk and also required escalation of care. The sickle cell disease, directed therapy such as transfusion and hydroxyurea are found to be to improve the outcome when they have COVID disease. However, as I said before, the long-term outcome still is unknown. So this again, on this study here, the sickle cell disease related mortality rate was seen to be found to be increased in 2020. So normally, so beyond 2020, 2019 and beyond, there was always a change in the mortality rate less than 5%, but there was an increase here from about to 12%, so which is a difference was about 80% for overall increase from 2019 to 2020. So this study from the UK Biobank found a significantly, so study was done on sickle cell threat carriers, and they found that there was no difference in terms of severity, in terms of incidence of incidence of COVID infection between the person with sickle cell threat and control group. However, the mortality was higher in sickle cell threat compared to control group. So by 12.6 to 28, so quite significant. So the reason for this was not clear, and the further study are required to understand what's going on there. So again, this study here in the US, the pediatric sickle cell disease pandemic review for one year in all the children presented to the hospital in Washington, DC. Again, here they found that most children developed had mild to moderate disease. And in terms of symptomatology, so fever was the most common reason of presentation. And these children have less loss of taste of smell compared to adult population and the rest of the population. There are difficulties, as I mentioned before, so the clinical symptomatology can be quite, similar, seen in both conditions. So clinicians should be aware, and patients should be aware when they have a temperature to seek for medical assessment and prompt medical evaluation for appropriate care. Now, just because we have now an effective vaccine, it was important for me to say I should talk about this. So it's first clear to, we should say that there was some case report of vaso-occlusive crisis following the administration of AstraZeneca vaccine, which is basically a DNA vector vaccine. But this are not many, there were like 3 cases. So this prompted this review of electronic medical record, where it's reviewed of 123 patients with sickle cell disease, with 87 vaccinated, mainly with Pfizer, Moderna, and J&J. This, so not AstraZeneca was not included here, and there was 36 unvaccinated. So there was no significant complication. Less than 1 patient presented to the hospital within 7 days of vaccination. And there was no differences in terms of hospitalization or on a sickle cell patient who was vaccinated. And only 1 patient reported a possible case of sensory or hearing loss when we see this one received Pfizer. It's unclear what the reason for this is. And there was no thrombosis or death reported. So, so the vaccine, COVID vaccine in adult with sickle cell disease is not associated with increased rate of pain crisis or any other complication compared to the general population. Now, the other question is a patient with sickle cell disease, are the immune system able to respond to the vaccine? And this study in Greece has looked at this, and they found that yes, the level of neutralizing antibodies against SARS-CoV-2 were adequate after 2nd dose of mRNA vaccine. And perhaps also there was association of complement activation. However, there is a more study underway currently to look at how long immune response will last and whether it remain adequate for a long period of time. So that is to be seen. This just these are the data from the US registry of sickle cell. So far up to March, so this is from May. So 1,045 cases of COVID were reported in a sickle cell among sickle cell disease patients. Again, there's no significant difference in sex, but obviously the Blacks and Hispanic were more represented here. And unfortunately, the rate of vaccination is lower among Black American compared to the rest of the population, and also so the patient of the sickle cell disease. So this just data which I'm happy to discuss, but again, in this cohort, I mean, in this data, just episode was but almost 30%, and pain was one of the main presentation with almost 50%. That compares the difference from the children data we reviewed, which mainly most of kids presented.
Dr. Kalumba, sorry to interrupt. Just in the interest of time, just would like to remind you that we just need to start wrapping up. Apologies.
Yeah, so basically this is just the data we can review. So conclusion, sickle cell is recognized as a risk factor for severe COVID disease. So that CDC has recognized that as well. So we all understand that. Of course, COVID-19 disease on sickle cell patient increase hospitalization risk and mortality. And this possible sickle cell threat may also be at increased risk of COVID, moderate to severe COVID disease and death. Vaccine is safe, so patient of sickle cell should take the vaccine unless they contraindicated otherwise, and they should continue to observe the hygiene measures, barriers, and the rest of the recommendation to prevent getting the COVID-19. More study are obviously needed to understand more, And hopefully in a couple of years to come, we'll understand better this condition. So thank you very much for your time, and happy to answer questions. And consultation are welcome. Thank you.
Thank you, Dr. Kalumba. Any questions in the room? No questions? Any questions on the chat that Dr. Kalumba might need to address? No. Okay. Thank you, Dr. Kalumba, for that great presentation. And I will just hand over to Dr. Manika.
Thank you, Dr. Kalumba, for that lovely talk. We are on to our final speaker, who's hung out all day to be doing this presentation. So it's my pleasure to invite Dr. Tina Carter up. She's presenting Pediatric Sickle Cell Disease in Western Australia. Dr. Carter is a pediatric hematologist in Perth and carries many, many hats, very impressive, of which is the most amazing pediatric hematologist and the only one in Perth. Thank you.
Thanks, Manika. Okay, girls and boys, it's the end of the day, I can promise you. And I thought this talk should be called Transition into Dinner, maybe. So it's going to be very quick. I'm actually going to not go over things that have been talked about today. I'm just going to give you something you haven't seen yet. So it won't take too long. Thank you, Agnes and ASCA, for inviting me here to speak, although next time I'm actually going to make sure you put me earlier on in the day, but that's okay. Just briefly, I have a background in oncology, paediatric oncology, and I was a director of bone marrow transplant. I'm also the apheresis medical director at the Perth Children's Hospital. And as such, over the years, I've learned a lot about collaboration, both national and international, and how important it is with rare diseases. And we've talked about that a lot today. And when Anthea came over, and she has been a fantastic collaborator and helping us in WA with our patient load of sickle cell disease patient load, I said to her, you know, I think that sickle cell disease is a bit like diabetes in the sense it's a vasculopathy, we know that. But also I deliberately picked that word, diabetes, because I don't know what it's like in Victoria and New South Wales, but in WA, the diabetes, paediatric diabetic department is huge. And they have amazing funding, amazing research. So I deliberately picked that for two reasons. One, because of the similarities, but also two, because I wanted to get some attention in WA about this disease, which is really important to keep these guys well. If we keep them well, they'll stay well. Just like diabetes, you replace the insulin, you reduce the vasculopathy. So now we have had some great talks today. Professor Ife Usunkwo was amazing, and so I am not going to do anything better than she did in terms of talking about the hope and how we can transition patients better from paediatrics to adolescents to adult care. I'll probably show you a little bit about how not to do it, which is what we do in WA. And we've talked about antenatal testing and screening repeatedly. And also, again, we do not have screening officially in WA. It's sort of an ad hoc approach at the moment, which is not working very well. Anthea talked about surveillance screening, which is really important because we do not want our patients coming in every week having lots of tests that we are not going to do anything about. And I thank you so much, because we do a lot of screening in oncology as well, and we have done over the years, and it's the same thing. If you're not going to do anything, why are you doing it? And it also causes a lot of anxiety, and I've learnt that in oncology. People get very anxious about their scans, and, you know, chances are the scan's not going to show anything. So when to do it is important, and what you're going to do about it, very important. And also about transplant, and I could really spend a long time talking about transplant. we've transplanted one patient with sickle cell disease in Perth, not under my hat. I was away at that time. They did not do very well for a variety of reasons. So we have learned, transplant in this disease is very difficult. Gene therapy is something we're getting very excited about, and we have our new Director of Cellular Therapies in WA is Slatibor, is a gene therapy expert, and we are working very closely together. And my other little comment before I get on to my talk, which won't take long, is that you talked about the patients being warriors. And I think that is great because it's a sort of great term, a warrior fighting a battle, or a long battle really, isn't it? I would like the caregivers then because I think the caregivers are then like the shield maidens. If we're going to talk about Vikings, the caregivers are the shield men and the shield maidens. They're as important as the warriors. So I was just thinking about them. Now, where do I point? To you? To that? Which direction? Right. Importantly, I want to acknowledge country because, the Indigenous people of this nation could teach us a lot, can't they? And we are only just starting to discover things about the health, the social welfare, the culture that can help us look after this country and our patients a lot better. So I thank them, and I'd like to acknowledge it's the Gadigal of the Eora Nation who are the traditional custodians of this area. And I'm told you're not meant to pay respects to emerging leaders. I'm told that you just pay respects to past and present leaders. That's Australia. You know what Australia looks like? And WA is very big, isn't it? And Australia is very big, but WA is very sparsely populated. So you saw how big WA is. We have currently about 50 patients that are between the age of 0 and 17 with sickle cell disease, sickle cell anemia. And in adults, there's about 115 on the registry, but no one knows how many adult patients we have in WA. So I'll talk a little bit about that. So that's the sort of metropolitan area, southwestern region. So that's the metropolitan area. And I was playing with on the way here on the plane, which you just have to excuse me, I'll pick it quickly. Here are the major teaching hospitals. That's PCH, Royal Perth, Charlie's and Fiona Stanley. And what do you see? What do you notice? Of course, WA is really big and all the tertiary hospitals are just there. It's that little region. Now, most of the population is there as well, I'll give you that. But, there are patients and we look after patients all over the state. We have a good history of looking after oncology patients all over the state. Giving being Christine up in Broome and looking after haemophilia patients in all sorts of places. And I think because of telehealth as well, we have now establishing good ways of looking after patients with sickle cell disease as well. But we have a lot to learn, I have a lot to learn. So I did have 55 patients. 2 of them have gone back to Africa recently. I'm very worried about them because they're actually patients on transfusion. And 3 of them I just recently transitioned to adult care. And oh my dear, transitioning them to adult care, I was so worried about them. So in the adult land, we don't know how many patients there are. I'm told there are 3 patients having red cell apheresis. 2 of those were our old patients from PMH. And 1 patient having red cell apheresis at Fiona Stanley. None at the moment at Royal Perth Hospital, where there is a really good apheresis service. So who is looking after these adult patients? Well, mostly registrars, actually, because the adult haematologists look after oncology patients, and it's very hard for me to get them. Kylie as an exception, and I'd love her to come to WA, but they tell me they're too busy to look after patients with sickle cell disease. Dr. Agnes Young has put up her hand to look after the adults, and I'm really keen to establish a centre of excellence at Royal Perth Hospital, but of course then she has no FTE for it, no clinic availability. So now all of our patients pretty much are on hydroxyurea, and I thank Professor Cole for that 15 plus years ago. We have no patients really not on hydroxyurea. And I think I did some training in Canada at British Columbia. And I saw a lot of patients with sickle cell complications there, acute chest syndrome, acute crises. And really over the decade or so, we've been putting these patients on hydroxyurea. Touch wood. I don't see many complications apart from patients who are non-compliant, where we might not have the hydroxyurea dose quite right for that patient. And then the other unknown, what it is about that patient, that their hemoglobin F is high, but they still have symptoms. So I have 35 patients born in WA. At least 8 of those patients were not picked up, and we picked them up later through orthopaedic surgeons, MRI, doing MRIs, because the person came in with query osteomyelitis. And of course, you know, the diagnosis the poor parents get told, and I'm sure we've all had that experience, maybe not, is it could be leukemia, it could be infection, oh, it might be sickle cell disease. And, you know, I walk in the room and there is this little chap sitting there from Africa, and I think, okay, right, guys, look at this child, look at their white cell count. They're not going to have leukemia. Have you examined their abdomen? They haven't got a big liver and spleen. Or they might have a big spleen. So peripheral hospitals with pneumonia, that's another way they come to us, and the lovely local GPs who are often very good at picking patients up and have good relationships with their parents and patients. I have 20 patients from overseas, and as we've talked about today, those patients and their parents often don't speak English as their first language. It's a cultural shock. They may have had huge traumas even before they've even got on a plane to come to Australia. So it's a huge challenge for them, especially, and for us to work out how best to help them. We have great surveillance protocols. We wrote them because we're good little oncology people. We wrote good emergency and respiratory protocols. And then in generosity, I sent them to all the emergency departments and the adults who accepted them gratefully. But then I still don't hear back about how many patients they've got. We review them regularly, and I'm currently also working with I don't know, you don't call it SWAG. I just wrote SWAG because I thought the Sickle Working Australian group, I don't know. We unfortunately can't deliver at the moment red cell apheresis as a regular service because we just don't have enough staff and FTE to actually deliver that. We do have the skill because we do a lot of other apheresis. So we do offer it as an emergency service at the moment. We've been FACT accredited for a while. I think I started writing the protocols in 2007. So it's very frustrating for me that I can't get this red cell apheresis happening, but it will happen. We're currently, we moved from Princess Margaret to Perth Children's in 2018, and we merged labs from a little lab to a big lab and merged hospitals. We lost a lot of staff in the move for a lot of reasons. Don't go there, you can ask me later. And I have been fighting for FTE, fighting to organise clinics, get a social worker, OT and physio, and I finally got the FTE, but then of course COVID happened and it's taken a while to fill those jobs, but we'll get there. And we also have a lovely clinical psychologist, and he and I sat down a while ago and we are looking at a research application looking at cognitive function in some of our patients, which is really important, and mental health, which we've talked about as well. We have 8 patients, and I talked about this on regular transfusions. We know why, well, we sometimes don't know why they need regular transfusions, but sometimes it is poor compliance. I'm not going to go into the complications of transfusion because we've discussed it enough. And I guess this really is always to remind me why I want to use automated red cell exchange transfusion on my patients and the steps it will take for us to get there. And this picture I did on the plane. I was very proud on my way over because these are my patients having red cell transfusion. So they're not having exchange, red cell transfusions. And we're thinking about transition, yes. So that's the age at the bottom of those patients, and that's the ferritin level of those patients. So as you can clearly see, and the ferritin, you see that line at the bottom is 1,000, so well below 1,000 is normal. So you can see what happens to those patients as they get older, just my little cohort of 8. Now, of course, it's a small population of patients, but I suspect it's the same everywhere because these patients are on iron chelation therapy and hydroxyurea and having transfusion, and guess what? They don't always take their iron chelation therapy, and who can blame them? Again, these kids, I see them and think, must be hard to take this many tablets a day, So, and then what's going to happen? I'm going to be transitioning them to who knows where. We know that just in terms of complications, and sorry, Anthea, these are some of your slides. I pinched off you gave them to me, I lent them, whatever. And we can see that these complications of these patients as they get older, they change. We can see that the survival of our patients is great. We want them to live. We want them to be well and healthy. But what's happening in that group between those young adults here and the number of deaths? We need to do something about this population of patients, and obviously people like Professor Iffy are already addressing, lots of people are addressing this issue. This transition is such a high time of risk. Of course, whatever, I love the description of adolescence being the disease. It is, isn't it? We know I've got grown-up children. I went through they went through adolescence. I was experiencing it with them. They didn't have sickle cell disease, but they have all sorts of issues at a very, very high risk time, and then they're at risk of complications of their disease, and they want to somehow struggle with their own independence and self-management, and we have to support them in this. We have to, or we're letting them down. What was the point of looking after them all those years, keeping them well, if they're not going to do well when we move them over? So as I've said, they go over to the adult hospitals, and at the moment there is no one really responsible for patients with sickle cell disease. It used to be Sir Charles Gardner, but it isn't actually now. One patient I transitioned recently, I've put it up there because I was heartbroken. I worked with Agnes. We worked to make sure she was transitioning to Royal Perth, that Agnes was going to be responsible for her. Agnes Fong, that is, not you, Agnes. Everything was lined up as much as we could have it. She was a gorgeous girl, and in fact, I wanted to show you some of her artwork, but I didn't have time to ask her for permission. And what happens? The ambulance won't take her to Royal Perth. So they take her to a peripheral hospital where no one rang anybody. No one could get IV access, which I'd gone over lots of times with Agnes. This girl has really difficult IV access. Please, make sure she has a long line straight away. All those things we handed over, and the ambulance service would not take her to Royal Perth. And it's so frustrating, but each time I told her, we learn, we will get it better the next time. The screening is a real issue for us, especially in WA. We did used to have a service at King Edward Hospital with high-risk pregnancies. Professor Cole started it off many years ago that high-risk individuals should be screened for sickle cell disease, but sadly she's not working in Perth at the moment, at the tertiary hospital anyway. And that sort of screening platform has dropped off. So it's very ad hoc. And really there is a lack of recognition of this disease, isn't there? I mean, I don't need to tell you all this. So it's a chronic disease, and it's like diabetes, it's a vasculopathy, and we have to keep these patients healthy so they can have healthy lives. So quickly acknowledging Anthea, thank you very much, Anthea, Anthea came over to WA recently, and she's been a fantastic collaborator. Thanks to Kathy Cole, who is my mentor and a great friend of mine, who really started our patients on hydroxyurea a long time before a lot of other people around the world, because she read all the baby hug stuff, and she said, we need to start treating these patients. Nat Gamble-Williams is our CNS. She is amazing. She does everything, and it's, that's why I've been trying to get OT, social worker, and everybody involved, and also to Erica for the registry. So that's it. That's me done. I think I was probably even less than 10 minutes, wasn't I?
Thank you very much, Tina, for that. And it certainly regenerated us all. We're all very excited now. It's fantastic. I don't know if we have any time for questions, but if there's anyone who had burning comments and questions, we could certainly take one.
Just a comment, just a quick thank you, Tina, and the lovely work you are doing. We are Perth born in the sickle cell family. Kathy Ko, Dr. Greenway, and all the names up there, they've really been helpful for our family and as an organization as well. So just thank you. And hopefully I come and meet the patients when I come next month, or is it later this month? But thank you so much for the work you're doing. Thank you very much.
I am very proud of myself. I am letting you out here at 6:30 as I promised. I apologize for those we rushed through, but thank you so much for staying till the end, everyone. In closing, I am going to ask Agnes and Preston Sofwa, the co-founders of ASCA, to just come to the front, and Natalie as well to come to the front. Natalie is also a co-founder of ASCA. And Agnes has been talking a lot. She doesn't want to talk anymore. So I'll just give final remarks. We'll hear from Preston, Natalie, and then I will close.
Can I use this? Yeah. Hi, everyone. My name is Preston, Steve Head. I'm one of the co-founders. But all the hard work has been done by Agnes. I'm in the support in the background. So I'm really, really proud of you for all the work that you do. You're very selfless, hardworking. And to the team and everyone who's been here, congratulations. You've done a fantastic job. It's been a fantastic day. I'm supposed to be at work, actually. I drove in from Orange, New South Wales. Took me 3.5 hours to get here, but it was worth it. And yeah, I'm glad I was here, and it's been a fantastic day for me. I learned a lot, I've enjoyed it, and congratulations once more, Agnes and the team.
Okay, thank you very much to everyone who came along. This was a really wonderful day. Gosh, I've learned a lot, and I'm probably sick of hearing my own voice right now. But in any case, what I wanted to say is all of this would not be possible, of course, with Agnes and her tenacity. I mean, I was certainly dragged kicking and screaming into this advocacy work, even though, like Mwewa said, I do have skin in the game as well. But kudos to Agnes and the team. They have been fantastic. Particularly this year, I haven't been as involved due to personal commitments, but it has been an absolute pleasure, and I'm just super proud of all the work that has been done, really. I'll just say thank you. Thanks, Agnes, and thanks to the team. And we hope to see you next year again.
I think that's it. That's the closing remarks. That we are back again next September, and just thank you. Seriously, I've got tears. You can't see them, tears of joy, like hard work for the past year. But thank you so much for our doctors and all the team and everyone. Mayase has been very instrumental in all this. She found this fabulous venue, and seriously, everyone, my friends who flew in from Perth, my lovely husband for missing work, and everyone here. So thank you. We'll see you next year, September, Melbourne.
All right, so we're coming back next year, 2023 in Melbourne. So on behalf of ASCA and the entire organizing committee, I want to extend a hearty thank you to our volunteers, camera people, everybody who's been working hard today. And before that, to get this program going, our speakers for sharing with us today. We still have much work to do for sickle cell disease. So let's keep advocating and let's keep caring. And also, I know a lot of people have flown in, so travel safely and we'll see you next year.
Yeah. And just to our speakers, we are going to send you some presents. So look out for your email addresses, emails and everything. We'll be sending you presents in the mail soon. Thank you.